অনুপম তো রং করিস থাকে
রং করেছিল বহুদিন আগত কিন্তু ভিতরটা
Mr. Viraj
স্টার্ট করা
now the Mr. Viraj, we are starting. Yeah, Mr. Viraj.
Hello.
Yeah, you open,
Yes.
You open it.
Hello, Rahul.
Hello, Beto.
ঠিক আছে তো after a long time.
ঘৰতে বহি আছো
Okay, গম পাইছো।
আপোনাৰ মেসেজ টু স্টে হোম স্টে সেফ ফলো কৰি আছো।
राहुल तो मोटा हो गया।
हाँ सर,
राहुल मोटा हो गया घर में बैठ के।
सर क्या करेगा घर में बैठा बैठा और कोई काम नहीं।
So sir, we are starting the program, sir.
Yeah.
Yes, sir, we are live now.
Anupam, sir. Yeah, live.
Okay. So
Yes,
good evening all.
Yeah, sir. Sir, I am just giving small introduction. I am giving, sir.
Okay, sure.
Yes, sir. Yeah. Once again, good evening, sir. On behalf of Alcom Laboratories, India's fifth largest pharmaceutical company, I, Nazrul, welcome our eminent doctor who have joined us for today's panel discussion titled Views on Vildagliptin. To help us navigate through the meeting, we have with us today Dr. Anupam Datta sir, who will be our moderator for today's panel discussion. We take this opportunity to welcome moderator of the day. Dr. Anupam Datta sir is one of the leading physicians from Dibrugarh and professor of medicine from AMC. Also, I would like to introduce to you our galaxy of panelists, Dr. S.C. Sharma sir, senior consultant physician and cardiologist from Dibrugarh, Dr. Rashmita madam, one of the leading consultant physician from Tinsukia, Dr. Ramesh Agarwal sir, senior consultant physician and cardiologist from Tinsukia, Dr. Rahul Bagaria sir, one of the young consultant physician and diabetologist from Tinsukia. We would now invite Dr. Anupam Datta sir to set the context and start our panel discussion. Over to you, sir.
Thank you, Nazrul. So
Yes, sir. Thank you.
yeah, so today's evening we have gathered here to talk about a molecule vildagliptin. As we all know that the concepts in diabetes have changed drastically in the last few years. When we had studied, it was always about the triad, about pancreas, the secretion of insulin from the pancreas, adipose tissue leading to insulin resistance, and lastly it was about the insulin, the GI tract. But now whole concept has changed and we have come to the omnious octet, when not only we talk about the insulin secretion from the pancreas or from the GI tract, we also talk about the brain gut involvement. We talk about the renal excretion of kidneys, from the kidneys. We talk about the involvement of the muscles. We talk about so many other things, and that makes it a holistic approach. And when the concept of the holistic approach came, that's when the concept of multi-drug and various drugs which work in different ways has come. DPP-4 inhibitors have been there with us for a long period now, and there has been various types of DPP-4 inhibitors, and we all know, all of us have used them in our private practice as well as in our clinical and academic studies, and it is now a well accepted and beautiful module of treatment that we use in diabetes mellitus. Now, vildagliptin as a molecule has recently become off patent, and hence the price has come down to almost 1/3 of what it was earlier. This has opened up the gates to various people for whom vildagliptin was earlier beyond their economic reach or beyond their availability. So now when this molecule has become a more available to all the people, it is now time that we need to discuss more about it. We need to tell and prescribe this drug more, and hence today our meeting. So in our meeting today, we have various things that we will be discussing one by one, step by step. But let me start our panel discussion with Rashmita Baido. Rashmita Baido, is a leading physician from Tinsukia and my senior. And by the way, I would like to ask you that given the progressive nature of a diabetic patient and the type 2 diabetes mellitus, how do you view the combination therapy of a strategy, the combination therapy of vildagliptin with other drugs, especially in the background of the Verify trial, which was recently conducted?
Thank you, Anupam, giving me this opportunity. For this, you have allowed me first to talk on this. In fact, after like off-patent, vildagliptin is, I think, one of the best molecule to start and initiate. Because earlier we used to, because of the price and all, we have to choose for sulfonylureas first. And normally we know that in sulfonylureas, usually there is an OHA failure is very fast. But as off-patent is there and the price is reduced, everybody has got the chance to use a better molecule. So with this, the use is increased drastically, and we are getting the benefits of the molecule. And once the patient started, this OHA failure is, in fact, I'll say very late. In fact, the patients are continuing with the vildagliptin for a long duration. In our practice also, I have seen the patients are, you don't have to change the prescription every time the patient comes because they're maintaining their HbA1c level. So with this, I'll just talk on about the Verify trial. We everybody know it's a Verify is a study to, it's a glycemic durability of an early combination therapy with vildagliptin and metformin versus sequential metformin monotherapy in newly diagnosed type 2 diabetic patients. It is a 5-year multi-center randomized double-blind trial study. In this, this is a trial. It was conducted in. Study was published in 2019 in a EASD conference. The trial period was 2014 to 2019, and the enrollment began in 2012 to 2014. So it was done in 254 centers across 34 countries. The study consisted of a 2-week screening visit and a 3-week metformin running period 500, 1000, 1500 or up to 2 milligram. And after a 5-year treatment period, which was again further split into 1, 2, and 3. And here the patient were enrolled in the age group of 80 to 70 years, HbA1c taken in the range.
Madam, or network wala issue hai sunni.
Yeah, I think there's a network issue. Bado, can you hear us?
Yeah, probably she's having network issue.
Network issue.
I have also suddenly in my home electricity problem is there. I am coming to the veranda. So,
yeah. So what we do is in the meantime, let's wait for 1 or 2 minutes. If Bado cannot join, I think we will go to Shubhasda for our next question. Yeah, I think let's move on to our next topic. We will go back to Rashmita Bado once she has come back online. So Shubhasda, our next discussion topic is what do you think about the role of vildagliptin in the elderly, and overall what do you think of the role of the management?
Sorry.
But if you kindly continue.
Sure.
Yes. yes, madam.
Yeah. So like in the study period, the patient were I have already told like, and they were in the HbA1c 6.5 to 7.5, BMI 20 to 40 kg, and then 1:1 they were randomized to two groups were one placebo group, metformin plus placebo, other was metformin plus vildagliptin group. And when they're enrolled, again the patient were screened at usually 13 weeks apart, like every 3 months apart they were seen, the HbA1c level was seen. And if the patient if they didn't maintain the HbA1c of below 7, if the patient is in the placebo, they are taking the placebo, they have given the vildagliptin 50 mg twice daily, and the patient they entered the study period 2, during which all patients received the combination therapy. So the primary efficacy endpoint was the time from randomization to initial randomization to initial treatment failure, defined as HbA1c measurement of at least 7% at 2 consecutive visits, like 13 weeks apart. So the full analysis was conducted up to like 5 years. So the conducted, and like this would have seen that it has been seen that when patient were usually in the metformin the plus placebo group, at the 3 years period, usually there is an OHA failure has been seen, but the patient who were on the vilda plus metformin combination, they usually sustained their durability up to 5 years. So with this, it has been seen that when patients were started with combination therapy from the beginning, they maintain their HbA1c levels, and usually the hypoglycemia, weight gain, other parameters were maintained. In fact, hypoglycemia rate is also almost like same with the metformin group. So there is no such emerging side effects has been seen with the combination when started early. And some of the patients, if they were on the treatment failure, they were started on insulin. So a significant reduction in the relative risk for time to initial treatment failure was observed in the early combination treatment group when compared with the monotherapy. So early intervention with a combination therapy of vilda metformin provides a greater durable long-term benefits when it is compared with the current standard of care with initial metformin monotherapy. So with this, I would like to say to the audience or everyone that if we initiate the vildagliptin early in our treatment, the sustainability of HbA1c maintenance has been seen, and as a whole, when HbA1c is maintained, the complication part will be less. So this, thank you. And Anupam, you can go ahead.
Thank you, Vaidya, for this very brief and to the point description of the verified trial. The verified trial has put forward the importance of combination therapy, especially with the DPP-4 with metformin. And they have also said the earlier the involvement, the earlier the use of a double therapy or probably a combination therapy ends up in a long-term benefit, which we have seen actually in various other diseases. We have seen this in hypertension now, that they have advocated using multiple drugs or a combination drug earlier. We have seen this in tuberculosis, which was earlier with 1+1+1+1, and now we go for a combination therapy. And hence the combination therapy concept has come forward, and which has now said that diabetes is no longer goes for the treatment to fail, which is add one drug, wait for it to fail, and add another drug, wait for it to fail. So this treatment to failure concept has gone, and now we have come down to the combination from the earliest. By the way, please stay with us because we have various other topics to discuss. Next, we'll go to Subhasda. Subhasda, with your experience, how do you think about the role of the management overall in an elderly patient and specifically vildagliptin in an elderly, where what's its benefit and what are the important points one should keep in mind when we do such a therapy?
Thank you, respected moderator sir and my co-panelists and respected audience. This topic means as a whole DPP-4 inhibitor in elderly has been given to me. So elderly, as we know, it is a very special group in all the medicine part, not only in diabetics, in every aspect of medicine, we do always give a special interest and special subject to these elderly people. And space in relation to the diabetes, as we know, now it is increasing in prevalence, not only in young and adult, but also in elderly. And we know now more than 50% of the patient of diabetic is of at the age of more than 65 or equal to 65 of age. That means approximately 20 to 30% of the elderly population have diabetes. So it is a very bigger population we have to deal. And in coming years, I think as per the IDF assessment, International Diabetic Federation, the world have to bore about 200 millions of elderly people with diabetes. So this is a very real concern. The thing is that inherent to the elderly population, we have to know first of all, before starting any medication. So especially elderly we know that all the homeostatic mechanism and organ system are in a blunting phase. Somewhat they have a decreased performance in relation to the young adult. So another thing is that the pathophysiology of diabetes itself is somewhat different because the reserve of the pancreatic beta cell is decreasing and there is more apoptosis of the cell. Mitochondrial dysfunction has also occurred in this category of patients. And another important thing is that now the concept is coming also that along with the beta cell, we do have alpha cell dysfunction in diabetic population and especially in elderly. So at this, when we're dealing with beta cell with different medications, it means diabetes as a whole, then we have to see whether that medication has somewhat effect in alpha cell also. So this is another important thing. And other peculiarity in this population are we all know about, are aware of about this, that this population is a very heterogeneous group. That means we cannot say as elderly in one group because some of the elderly, say especially 65 to say 75 age group, some majority of them or some of them is a very healthy and some of them are frail, and above the 75 are mostly they are frail elderly. So we have to see that part also because control of diabetes is very important. If we see the life expectancy and the other adverse effect in relation to the other organ system, likely in the kidney, in the even cardiac part also. So that means what I have to give importance in relation to that some of the elderly patients who are healthy but have diabetic or especially newly onset diabetes, in that patient we have to be somewhat more aggressive. And in the other hand, in the other elderly who are frail, have many comorbid conditions and organ dysfunction, especially in relation to the cardiovascular system, in renal system, and most of the patient with that patient, more than 50% we see have a renal diagnosed or undiagnosed renal dysfunction. So that means they have a multiple comorbidities with may have multiple organ dysfunction. This is a very important in relation to any drug before we're going to start. Third thing is the polypharmacy. This is another important issue in relation to again in the medical science, because most of the patients do have many diseases, many comorbidities, hypertension, diabetes, cardiovascular issue, dyslipidemias, as well as this population has also some issue with the brain, nervous system, because most are dementia, cognitive dysfunction, depression, loneliness. Then social environment is different. The support system is also important in relation to the treatment, whether they live alone or whether they have a very good support. So before selecting any drug, so we have to see all these factors. Cost and other factors are definitely important. And because of polypharmacy, so any medication, again, before starting, we have to see about the drug and drug interaction and adverse effect. This is very much important. Then third point is obviously another important issue in relation to the hypoglycemia. We do know and we are aware of that hypoglycemia is a very frequent occurrence in this group. And not only that they are frequent, but they also usually severe, because we know that they do not have the hypoglycemic awareness, that reflex is diminished in this patient. So they do have diagnosed, undiagnosed hypoglycemia, and because of hypoglycemia, the mortality and morbidity is much more in this group. So we, at any cost, we should not produce hypoglycemia. So before going again, for selection of drugs, we have to see that factor also, whether that drug has a propensity to cause hypoglycemia or not. So this is another important factor in relation to this. So considering all the factors, and also and another important issue I have forgot to tell, this is the population which are usually have a low representation in the clinical trials. So we do not have a very much information or data from the trial. So we have to see that factor also. So we have to be very rational, and we know the drug, we have to know the pharmacokinetics and dynamics of the drug, about the drug well before giving the drug. Now coming to the DPP as a whole, as a class, we know this has been launched in the year, I think, 2007. And especially vildagliptin has been launched in the 2007 by Novartis, I think. And initially it has not been approved by FDA, US FDA, because of some concern about this drug. That concern are, say, this is in relation to the cardiac effect, CV effect, in relation to the pancreatitis, in relation to the immune function, because we know that DPP enzymes, they are present in every tissue of the body, not only the pancreas, they have every tissue, and especially in the immune tissues. So whether about the immune system, so there is a fear about that. So infection, then another important is the arthritis, then some of the cancer also. So these are of the some major concern initially just at the time of the launching of this medicine, but later on different trial and different meta-analysis and this expert report has said and has have a conclusion that these are not seen in the real scenario, and it's a very, very, very less occurrence of some of the minor side effect as like the other medication and as compared to the placebo. So DPP-4, as we know, is a very good drug because we are using for last 5 to 10 years. I am also personally using especially vildagliptin because I have seen this drug as a fast in our setup. I think probably it was the first launch here. So I am using for last 5 to 7 years in all patients, and majority of the patient, more than 50%, I am dealing with cardiac patient also. So from my own experience and the trial, there are trials like what already that verified trial. This is another important trial published, I think, 2019, and VIVID trial was there initially, and other trials are there. So all the trial have shown that vildagliptin along with other DPP and cardiovascular outcome trials are there, CVOT trial. So this trial has shown that in relation to the cardiovascular system, DPP are benign. So neutral, we can say. They have no adverse effect in relation to the cardiovascular mortality, in relation to the ischemic heart disease, in relation to the other cardiovascular, as a whole cardiovascular disease. So this is a very important thing because this is the main driving factor in relation to the mortality and morbidity in this category of the patient. So this is a very important thing. Though we do not have added advantage in relation to this system, but we can say that it is neutral. That at this point of time, we can say confidently that DPP are neutral. Even in my practice also, I have seen a lot of patients with cardiovascular system. I have started DPP, especially vildagliptin. Now I am also prescribing other congener of this group and having a very good effect. So thing is that as a whole, DPP is glycemically very effective drug So is as effective as metformin. And if you compare with the metformin, all the side effects, including the hypoglycemia, is nearly same. Most of the studies has said 0.6% with vildagliptin, and as compared to 0.4% with metformin. And in relation to the other organ dysfunction, especially the renal dysfunction, we have to see. Then vildagliptin and some of the DPP, other DPP also, they can be given without any hazard in mild to moderate renal dysfunction. So up to, I think, creatinine clearance above 50 ml per square surface area, meter square. So that we can give this DPP4 inhibitors vildagliptin also. So this is another important. In hepatic dysfunction also, we can prescribe DPP without any fear, because we know that DPP is in relation to the vildagliptin. Among the DPP, it has some other peculiar effect. Peculiar means property, like it is metabolized mostly by hydrolysis, and major portion 70 to 80% coming out through urine, and other 15 to 20% is goes through the feces. And it is very less protein bound, so it is friendly to the kidney, friendly to the liver also. And the effect is glycemic effect is a potent effect. I have said that it is as far as metformin and other hypoglycemic or anti-hyperglycemic agents. So in that way, if we see all these, so propensity to cause hypoglycemia, CV neutral effect, and other organ, like especially in renal relation to renal functions, so it is a neutral, and we can give this drug without any fear. At this point of time, I can say that confidently. So in relation to that vildagliptin, vildagliptin, another important thing is that, as I have already mentioned, that alpha cell dysfunction is another important issue in relation to diabetes, especially in elderly. So the release of glucagon in relation to the food, and that means glucose, that is also somewhat blunted in elderly group, or especially in patient with diabetic, as beta cell dysfunction. So DPP, whether it is also same with vildagliptin, or whether it is also same with the other DPP, I don't know. But it is specially mentioned with vildagliptin that it also has a good effect on the alpha cell. That means it's also affect the glucagon kinetics. So thereby it prevent occurrence of hypoglycemia. That means it always maintain the blood sugar at a physiological level. So that's why, from the rationality of this, from scientific rationality also, we can say that it has a very less propensity to cause hypoglycemia, which is a major driving factor in relation to the use, especially in elderly. So last I can say vildagliptin is a safe, it is well tolerated drug in this group. It is safe from hepatic, renal, and most importantly cardiovascular dysfunction. And it is safe from other effects like brain, means CNS effect also. So I think this is much about vildagliptin, what I know.
Thank you, Subhasda. This is very elaborately, you have covered two very important issues. One, the overall management in elderly diabetes, and obviously the role vildagliptin plays, specifically because it is a very safe and very neutral drug. And in elderly, we do not want to take any risk because they are on polypharmacy, they have multiple comorbidities, and the number of complications in an elderly are extremely high. We can say that the complications which occur in a normal patient are heightened many times or exaggerated many times in an elderly. So better to have a very muted drug, a very neutral drug like vildagliptin than probably a sulfonylurea. Metformin in itself is a very muted drug in itself with many actions. Now, coming to the use of various drugs, I would also like to ask Dr. Ramesh Agarwala that what do you think about the use of various combinations? For example, sulfonylurea with vildagliptin, metformin with vildagliptin, SGLT2 with vildagliptin, or various other combinations. What do you think, and where do we stand on the use of vildagliptin along with various other combinations. Ramesh, I think you are muted. You have to unmute yourself.
Yeah.
Am I audible now?
Yes,
Ah,
yes,
yes.
you are audible.
Yeah, actually, vildagliptin, as we discussed, Rasmita also discussed about the verified trial. So vildagliptin is one of the DPP-4 inhibitor which is safe in combination with all the oral hypoglycemic as well as insulin. So the first and foremost, what we use is vildagliptin with metformin. It has been established that if we use vildagliptin with metformin, there is a synergistic effect as well as we can start as a first line as well as a second line treatment. So it helps neither to gain weight nor to have hypoglycemic events. So vildagliptin with metformin is quite safe, as discussed today also. So secondly, I'll go with vildagliptin with sulfonylurea and metformin. Suppose a patient is getting sulfonylurea and metformin, and there is not a good glycemic control, then we can add vildagliptin, which is quite safe, and we get a very good glycemic control and HbA1c reduction, as well as there is no change in the weight or we don't get a weight gain, particularly in the Indian patients. So it can be used with metformin, what we are using it for many years, and it can be used with sulfonylurea metformin combination and adding vildagliptin. So there is no harm in using, and all the studies, all the trials have shown the beneficial effect of vildagliptin in combination with other OHs. And the commonest now, then I'll talk about vildagliptin with SGLT2. Actually, it has got a synergistic effect with SGLT2, because what SGLT2 does, SGLT2 causes glycosuria, and but because of the glycosuria, why there is glycosuria in SGLT2 is because of endogenous glucose production is there because of gluconeogenesis. So if we add vildagliptin with SGLT2, the endogenous glucose production is reduced because of the glucagon effect, and as a result, it is neutralized and have a very good synergistic effect with SGLT2 and vildagliptin when used together. And there is the combination of SGLT2 plus DPP-4 a potential and a robust action on reduction of HbA1c. And with insulin, there is no harm. We are using it with insulin, and it has got always a beneficial effect when add on insulin, HbA1c reduction, as well as good glycemic control. So overall speaking, vildagliptin is such a drug which can be added with all oral hypoglycemic agent along with insulin. And now in this era of COVID, vildagliptin is also safe in diabetic patients who are COVID. With insulin, we can add vildagliptin. So I have personally used vildagliptin in diabetic COVID patients. So it has given a good glycemic control and very less chances of hypoglycemia. Thank you. I don't want to say anything more. Anupam?
Yes, Ramazda, it is what you have said is really good about various types of combination. I think we can also say that vildagliptin can be very nicely added with insulin, basal insulin as well as various other insulins, because they do have a very mild effect, and hence the chances of hypoglycemia is not there. Whenever someone is on high insulin and we do want to add a little bit of an oral drug to it, we can do that. And as far as your observation about COVID, it is very good observation that you have said that use of vildagliptin or SGLT2 in cases of COVID Only a little bit of a concern there, because what happens is in patients with COVID, they lose their appetite. The taste and smell goes away. And when the taste and smell goes away, their eating is a little bit of an issue. At the same time, they're on steroids. So what we have done in AMC is, whenever we are giving steroids, we usually shift to insulin so that we can modify. But in home isolation, probably this will work very nicely, like any other OHA. But overall, yes, this drug can be very nicely combined with various other drugs. One concern that many people have said is its use with acarbose and voglibose. So as this works preprandially or kind of with the GI tract, some people have said that acarbose and voglibose may not be a quite good combination with this DPP-4 inhibitors, because they do inhibit that receptors where the glucose involvement is there, and but there has been various studies on it. It's nothing that has come to any confirmation right now. Next, let us come to Dr. Rahul. Rahul, we wanted to, already Subhasda has talked about patients with CKD. Rameshda has also talked about patients with CKD in which vildagliptin can be given very nicely. So I would ask you to kindly elaborate on the use of DPP-4 inhibitors, especially vildagliptin, in a patient of chronic kidney disease.
So, first of all, a very good evening and warm welcome to all my colleagues, my seniors, and the team of Elkem for the opportunity. And very beautiful was there today. Very elaborate discussion on vildagliptin and various uses in elderly CKD cardiac patients. I'd like to elaborate only precisely on the CKD patients, chronic kidney disease patients. So, as we know from the KDK guidelines 2015 coming to KDK guidelines 2020, we have come to know that initially many drugs which were unable to use and was banned to use in 2015, some of them has got patent to use in 2020. Like, but till 30 eGFR, most of the drugs like metformin, SGLT2 inhibitors we can use safely. It has been recommended to use, but with reduced doses. But below 30 eGFR, we are left with very few options, like only insulin we can give safely. Coming to this, there are some other agents like DP4, like linagliptin is there, GLP-1 analogs like liraglutide is there, and semaglutide is there. These are the agents used in below 30 eGFR. But from past few years, we have come to know from this verified trial and other trials that vildagliptin at reduced doses can even be used in eGFR less than 30. And above eGFR less than more than 30 means stage 1, 2, 3, we can safely use the full dose of vildagliptin. And below 30, that is stage 4 and 5, and even in renal replacement therapy patients, we can use 50 mg vildagliptin, as also seen in the study. I'll just show the study. I'll share one screen. Here, adequate glycemic control is to delay the progression of kidney dysfunction, but there is a greater of experiencing hypoglycemic events, especially with longer-acting agents. So, how do you assess the role of vildagliptin in CKD? The study
Rahul,
was done to see that. Yeah.
Rahul, yeah, now it has, now the screen has been shared. Okay. Now it's visible.
Thank you. So, okay. So the maintenance good glycemic control is essential to patient, but also we should because group control will slow down progression of kidney disease directly or indirectly, and also we have to see the risk of hypoglycemia. So the outcomes we are seeing that vildagliptin is used in uniquely vulnerable population like elderly more than 75 years with type 2 diabetes and moderate to severe renal impairment like 3 to stage 5 patient, and 70% of these this kind of patient were treated with insulin. The main finding was that vildagliptin was efficacious with no increase in risk of hypoglycemia compared to placebo, despite a marked improvement in glycemic control. So vildagliptin can be used in type 2 diabetes with various renal impairment. In any stage of impairment, stage 1 to stage 5 of according to EGFR, and we use those when the EGFR is less than 30, that 50 mg vildagliptin. So conclusion is that it safely used type 2 with real impact. Dose adjustment though is required EGFR less than 30. So I stop this sharing. So with this, we come to know very few studies are there now, but at least we have in our clinical practice also we have come to know that reduced dose of vildagliptin can be a insulin therapy in stage 4 and stage 5 with EGFR less than 30, even in the elderly population also. So with this brief discussion, I'd like to end. Go for further discussion.
Thank you, Dr. Rahul. There are some issues in a patients with CKD. First of all, their sugar is never very high. Usually patients with CKD will have a very low blood sugar. Second of all, they are very prone to hypoglycemia, especially if they are on maintenance dialysis. At least at the time of dialysis itself, there is always a chance that they can have a hypoglycemia along with dyselectrolytemia. So in that condition, the use of a drug, oral drug, if they are taking oral drug, should be the choice should be something that it should not be very strong and it should not cause hypoglycemia. So sulfonylureas, though they cannot be used obviously in a very high creatine clearance, but also they have an increased chance of producing hypoglycemia. Insulin, though, is very good, but you need a very good monitoring in a patient of CKD to give insulin. In that case, there are some DPP-4 inhibitors, and I would like to especially mention about linagliptin. Linagliptin can be given very safely. It is a 5 milligram oral drug with 95% excretion through the hepatobiliary system, and hence the its use in CKD can be very useful, especially linagliptin. Vildagliptin, though is a very neutral, is not very potent, not very nephrotoxic, and hence its use has also shown very good benefit. But overall, the use of vildagliptin can be safely done in a patient with chronic kidney disease, provided that the patient is in not in end-stage renal disease and on probably not on regular maintenance dialysis. And also not in acute kidney injury, we can go for CKD. Okay, so with this, we have made a roundup of all the members in this discussion. I would just like to add, I would like to ask Rasmita Baido, what do you think about the use of vildagliptin what do you think about this price that has reduced, and what do you think will be the benefit of this loss of patency in all these patients?
Yeah. Yeah, thank you, Anupam. Yeah, with the price reduction, I have already mentioned, with the price reduction, its use has been increased rampantly. In fact, earlier we used to think of price and our hands are inhibited to write the molecule, because once you start BD's per day cost is 50 to 60 rupees. Now it's already around 10 to 20 rupees you can give. So with the lower price of sulfonylurea, in fact, some molecules it's lower than the sulfonylurea, you can initiate. And in fact, patients are getting benefited as a practically, we're not keeping so much of records and everything, but when we follow up patients, we're seeing the patients are in good control. And in fact, I have seen in the Verify study, the HbA1c range was very narrow, only 6.5 to 7.5. But with a higher HbA1c, in fact, in 9, somewhat till 9 also, I have seen the patients are getting good benefit, and the HbA1c reduction is quite good, and its maintenance is also long term, it's maintained. So I'll say in the verified study, the HbA1c is a very narrow range they are giving in the study. Maybe for the early initiation, I don't know. But with a higher HbA1c also, we can use and we can give the benefit to the patient.
Thank you, Baido. I think the off patent came very nicely. The timing was so good because we have lockdown and people are having economical problem, and it's in the good time that they have reduced the price. Subhasda, I have.
In fact, I have seen it. Yeah.
Subhasda, I have
in fact, this error.
Yes,
Just
Baido, continue. Yes,
adding
Baido,
something.
continue.
In this COVID scenario, like we're using so much of steroids and everything. Now, what I have seen, the patient were normoglycemic or just they have impaired blood sugar, but they're not diabetic, and they're needing like we have to add on anti-diabetics to that type of patient. And here I have seen use of vildagliptin is very safe. Like I have used in a lot many patients, they're just impaired diabetic, impaired blood sugar level, and with the addition of the vildagliptin, their sugar is also controlled, and they have a good outcome.
Thank you, Baido. Subhasda, I have one more question for you. As you do practice cardiology, and now we have anti-diabetic medications which have definite cardiac benefit, especially like EMPA, DAPA, and other SGLT2 inhibitors. Do you think in long term this anti-diabetic medications which has cardiac safety will outrun these molecules who are cardiac neutral, like all the DPP-4 inhibitors and other drugs?
Yeah, maybe that actually if cardiovascular disease prevalence we see it is increasing, and in some population definitely it is highly prevalent. So now we are selecting the agent which have as an anti-diabetic also, and at the same time it will also have a beneficial effect in other organ system. So like say your SGLT2 inhibitors, why they are coming like that way? Because they have a beneficial effect in relation to cardiovascular system. So patient with LV dysfunction and heart failure, the first line is now your SGLT2.
Yes.
So like that way, cardiac neutral maybe in that setting also it can come to in a second place, and that will go up, definitely take upper hand.
Yes.
But we have at the same time we have much more people without cardiovascular disease, and not only the disease, that organ dysfunction, because this type of drug is indicated in a special indication. Not all cardiovascular disease is you write SGLT2.
Yes.
Patient can have CAD, patient can have LVH, patient can, but only in case of LV dysfunction and heart failure, it is indicated now. Then now it is coming as an anti-heart failure therapy also. So in a heart failure also, even patient is not diabetic, we do have an option after, in case of refractory heart failure. We can write this as an anti-heart failure agent also.
Yes.
Thank you.
Thank you, Subhasda. Rameshda, I just wanted to have one more opinion from you. As you have talked already on details about the combination of SGLT2 and vildagliptin in your when talking about the various combination, I would like to highlight to you that many people in the post-COVID have cardiac problems. You have already seen many people have developed lung problem, and many people have had left ventricular systolic dysfunction, and cardiovascular complications are going to increase after this COVID. Many of the post-COVID patients, especially the elderly, will have some kind of an heart failure. And where do you think this combination of vildagliptin and SGLT2 will stand in their management? The voice is not coming. Ramesh, your voice is not coming. I think the mic.
There's some problem on mic.
Some problem with the mic.
Yeah.
Anupam, you can go
Ah,
back to Rahul. Then
yes.
again you can
Ra-
ask.
So Rahul, just we are almost towards the end. Till Ramesh does come back again. We'd also like to add you what is your personal experience, especially in the COVID area, about the use of vildagliptin, so that many of the pre-diabetes has now become diabetes.
Yeah, even even without the use of steroid, we have seen that in COVID infected patients, the blood sugar levels get very high. Both the fasting and PP blood sugar level, acute rise in blood sugar was seen even without the use of steroid. This is very surprising to see. As we know also that acute infection condition lead to hyperglycemia. My preferred agent is always insulin in these agents. In this case, preferably I use this basal therapy or basal bolus therapy or any premix therapy. If the patient is enough educated, or I can guide him over phone or something. But most of our cases, definitely, one second. In most of our cases, oral agents need to be given. And I think a more potent oral agent, I differ that more potent oral agents like metformin or even this sulfonylureas, I think they will work more better in this scenario. And because this will DP4, as we know, it has longer half-life. It takes some time to act. It takes more than 7 to 10 days for a more efficacy to come. So in acute setting, I would like to use a more potent agent. From my view, I think not SGLT2, because SGLT2 has seen to have some kind of ketosis. So sulfonylurea and metformin, I think we prefer it here, and insulin will be the first thing I'd like to start this.
Thank you. Very correctly said, Rahul, and that is what we are also following here in the medical college. Ramesh da, can you hear us now? Yeah, we cannot hear you. I think there is something wrong with the. So, okay, so if I think we have almost come towards the end of our 1 hour discussion on vildagliptin and various thoughts on vildagliptin. So I will ask Sinha sir. Sir, please come down to the planet Earth from whichever planet you are right now.
Sir, first of all, thanks a lot to all the doctors. Fantastic discussion, very nice discussions going on. That too in points. I'd like to say ask only one question. That is, as you know, that one more extended molecule, that is vildagliptin OD sustained release. I'd request Anupam sir, please tell something about this.
Okay, so there has been a new addition from various pharmaceutical companies where they have come with a vildagliptin sustained release. This sustained release, earlier why it was given in a BD dose? Because it has a shorter half-life. And the dose, there is a T half, the curve goes up very quickly and then comes down. So if we give once in a day, usually at night or in the second 12 hours of taking the medication, the drug is not in the therapeutic level. But with some kind of change in the drug delivery system and its sustained release formulation, they have tried to overcome this so that people can take one tablet once in a day. It is very new. Its use have been studied and being used right now. I think the real world data has not come, but many combinations, many companies have come with this formulation. And I think we will have to wait and watch to see what kind of effect it has. But definitely once in a day medication is always better than a twice in a day medication. And the compliance and the patient's use is also better when we have an OD medication. But the exact benefits can be seen after some time. Probably very shortly, in 6 months, we'll get some real world data and then we can say. If anyone wants to have any comment on that, Rashmita Bado, Ramesh ji, Suhasda or Rahul, you can tell if anyone has used extended release.
Yes, I've used in some patients once daily 100 mg. Definitely the compliance is very good. Once we can add a agent to giving a 50 and 100 mg once, compliance is always very good. And the efficacy part, as we can say that, so the full dose I think will work much better than a 50 mg dose.
I have not started till now.
Yes, I have also not started because theoretically what we have learned was it's about its curve is
BID dose.
and the T half is lesser. But let us see. Let us with the sustained LS
Obviously.
formulation probably we may.
Well,
get.
what happens now when there is hue and cries more? You have to then you have to go with the trend only. Maybe in
Yes.
course of time we'll start and see. But
With-
till now I have not tried. In fact,
Yes.
but
So-
not many molecules already in the market.
So I think
Yeah.
I will ask Nazrul and Mrs. Sinha sir to kindly give your final comments.
Yeah, Nazrul.
Yes,
Now
sir. Yes, yes.
Please.
Yes, sir. Yes, sir. Once again, thank you, sir.
By the way, how is the weather up there, Subrata sir?
In Calcutta.
No, in the planet where you are.
Oh. Thanks a lot. Nice. It's nice. Nice. to meet you.
Mars.
So
Okay,
once again, thank you very much, sir. We take this opportunity to thank Dr. Anupam Dutta, sir, for moderating the panel discussion, all the panelists for sharing their views on vildagliptin in clinical practice. We would also thank all the doctors who have joined us for panel discussion, and I am sure you will.
What has happened? I think connectivity issue is there.
Yeah.
So we are thankful to all the doctors who have joined. And on behalf of Alkem, I would like to, on behalf of Alkem as well as on behalf of Nazrul, I'd like to thanks to all of you for attending the program as well as, discussion was really very good. Very nice. And as you know, we have been conducting this type of program almost on every month. And it's all India wise we are doing. And I'm sure in future also we are conducting, and this will be benefited by all. I'm once again thankful to all of you, sir. And as you know, sir, we have one product that is Blue Vilda. It's available as Blue Vilda M500 1000 with metformin. Blue Vilda plain is also available, and Blue Vilda OD sustained release. We have also come out with price benefit also. It's only 10 rupees to the patient. And I'd like to share one thing. Just now I have received, one data from ORG. This is actually just 1 month back, we started this combination, we launched this combination, and only 3 brands are there. That is, one is from, there's USB, one is from Alkem, and one is one more brand, one more company. And you'll be glad that in Northeastern region, it is the second brand. Blue Vilda OD is the second brand. I will request, please try, sir. Please try. After then, decide. Thanks a lot. Once again, thanks to all of you.
Thank you, sir.
Thank you. Thank you, sir.
Thank you, sir.
Thank you.
Thank you, madam.
Thank you.
Thank
Rahul
you.
sir, thank you.
Thank you.
Rashmita
Thank you.
once again. Ramesh sir, once again, thank you. Shubhas sir,
Thank you.
thanks a lot. Thank you, Akol Okpam.
Sure. I am sitting here in the same place, in the veranda where I am saying.
Thank you.
Okay.
Good night.
Thank you.
Thank you, sir.
Okay,
Thank
good
you,
night.
sir.
Good night.
Sir.
Good night.
Good night. Thank you.
Good night. Good night, madam.
Okay, Anupam. Yeah, good.
Anupam,
You have
very good.
very nice
Very good.
moderated.
Yes, madam. Yes,
Shubhasda,
madam.
thank you. Bye. Yeah.
Bye. Ramesh da.
Rahul and Rahul.
Bye. Rahul.
Sir, thank you. Once again, thank you. Ramesh sir.
Yeah. Living.
Thank you, everyone.